what we looked at, as I said, was a large European cohort that was collected in a mixture of retrospective and prospective collection. All patients had biopsies and FFPE samples, and then had a gene array run on their samples. We also understand the radiation dose they received and their outcomes based on radiation, so local control and survival. Of course, we're dealing with, for the most part, HPV-positive oropharynx cancers, so the outcomes are quite good. However, what we were able to find was sort of three major findings. First, that for the first time in a single disease site, we had enough statistical power to show that GARD, so the genomic adjusted radiation dose, was a continuous variable predictive of outcome, which means that for every individual unit increase of GARD, we see a benefit to the patient's survival and local control. That's never been shown before in an individual disease site. Again, it always has been needed to do a pan-cancer or a sort of meta-type analysis previously. So that was very exciting. We then sort of dove a bit deeper into the data set and looked to see, I think it's quite common for radiation oncologists to think about one or two or maybe even three different dose levels for different treatments. So in head and neck cancer, it's quite common to think about 70 or 60 or sometimes 54 gray as different cutoffs. So what we asked of our cohort was, if we were able to optimize dosing levels, could we pick patients who need high, medium, and low doses to be optimized? And we found that, and I think quite strikingly, we found that there's two separate cutoffs that really tell us or help us predict how patients do, which really leads us to the hypothesis that we could use this to adjust dose to optimize individual patients. Of course, that's the hypothesis we need to test going forward. But what I think we can say quite clearly now, based on the final result, which I'll explain, is that measuring GARD or understanding a patient's genomic sensitivity to the radiation therapy they get allows you to better predict how their outcomes will be. So what we did was we created a clinical nomogram where we took all of the standard clinical variables, age, smoking status, stage, things like this, which are commonly used today in the clinic to prognosticate patient outcome. And what we did was we added to that GARD and also a genomic cluster from our collaborators in Italy. And what we showed was that nomogram far outcompeted staging as we do now. And so I think the exciting part about that is we sort of have a two-step result. We have something where we show that measuring the genomics of these patients' head and neck cancers can help us to understand better their outcomes today, even if we do nothing, even if we change nothing about their treatment. So that by itself is, in my opinion, is a strong mandate to start measuring this for all of our patients, so we can at least stratify them in clinical trials, tell them about their possible outcomes, have a discussion, and then secondarily use this as a clinical decision support tool for us as clinicians to consider adjusting dose. Right now in the clinic for head and neck cancer patients, we're already thinking about de-escalation for head and neck, for oropharynx patients with oropharynx cancers that are HPV positive. There's a strong move to lesser and lesser radiation dose. And so I think, and that's sort of done with clinical gestalt and other variables. And I think what we show here, in my opinion, convincingly, is that the addition of genomics really will help that decision-making and decision support between the patient and physician. So I think we have two nice results. One is that measuring the genomics now can help us to better prognosticate and have discussions with our patients and their outcomes. And secondarily, that we have a rationale to go forward to think about dose adjustment in the future as well.